Good morning, everyone. Cheryl Treadwell here from the California Department of Social Services again. And once again, I want to thank you for joining us on this final day of prevention planning convening. We hope that the information that we've shared with you so far has been informative and helpful in either getting started or moving further along in your comprehensive prevention planning process. I know that there's been an ask about our deadlines related to the comprehensive prevention plan. At this time, I would say that that's a consideration for us to look at, but we have to have a target date for you to shoot for, and we want to remain steadfast on, keeping you pointed toward that North Star. So it's not a final decision, but it's something that we'll take under advisement for consideration. But we're here to continue to provide technical assistance support and to help you try to meet that goal. We know that we've thrown a lot of information at you for these past 2 days, and there's more to come today. And I just want to remind everyone that CDSS recognizes the amount of work that is required to really uplift comprehensive prevention planning. And we're here to support you. And I would like to thank you for making that commitment to put in the work and be willing to do that work for developing the type of system that starts with prevention. And I also would like to take a moment to thank all of our partners today that made this convening happen and successful. So enjoy your day, pull up your sleeves, put in the work, and let's cross the finish line for today. And I thank you all.
Today we did a welcome with Cheryl. We'll do a quick recap. We'll talk about the comprehensive prevention planning readiness. We'll take a short break. We'll talk about the technical assistance support that will be available. And also we'll do a transition into a breakout room. So yesterday we were really honored to have the Sacramento prevention planning team that presented on their prevention planning process and also engaging community in the process. So we thank Sheila and Michelle for sharing that with us. We also had a presentation by Paul Collier from Safe and Sound, who reviewed the data playbook and considerations in the prevention planning process. We had some really, really great breakouts and who shared challenges about collaboration, timelines, capacity with data and staff and EBPs. We want to reassure you help is on the way. And participants also shared how the presentations and interactions helped inspire, motivate, and reflect on the prevention planning process. So it was such a wonderful day and lots of, I think, inspiring and motivating words were shared. So right now we wanted to do a Mentimeter just to share a couple of words to reflect on the experience of yesterday. Informative was one of the most used words here, inspirational, overwhelmed, and we understand that. We understand that all of this information can be very overwhelming. And we're hoping today we can help answer some questions and really sort of, help support the work that you're doing. Helpful. So now I wanted to introduce Dr. Kush Cooper, who will take us through getting the comprehensive prevention planning readiness. So I will hand it over to Kush.
It's always so wonderful to look at the little squares and see familiar faces. Happy Friday, everyone. And as we go into Pride Month, I want to wish everyone a happy Pride. And I want to contextualize that in that perhaps it's about celebrating family itself, right? And that's the conversation we are in. We're in a conversation about celebrating family and keeping families intact. Many of you know that I started working in the child welfare field 25 years ago, a week after my 22nd birthday. And it was at the Gay and Lesbian Adolescent Social Services group homes. And I have worked on the back end of the system for a long time and have been asked the question over the years and been asked to do studies over the years about, well, how do we serve LGBTQ youth in systems best? And my answer, I have come to realize after all that research, is prevent them from becoming LGBTQ youth in systems, right? So that's one way I came to talking about prevention. And then the other way I came to talking about prevention is my work with Cheryl Treadwell and Kelly Winston and Hillary Conrad and their teams at CDSS. And some of what you'll hear now is a result of all the learning and collaboration and conversations with all of them. So I just want to acknowledge those teams and celebrate them as well. I want to do a very quick level set on prevention, risk, and protection to contextualize what we're getting ready for. So what is a prevention-oriented system, right? And why do we want to reorient our systems to prevention? It is a reorientation. This is not a, I loved what Michelle said yesterday about it being a hike. It's a hike. It's a marathon. It's not a sprint or a high jump. It's about being disciplined and persistent about slowly moving a large ship that is your system toward orientation. Why would we want to do that? Well, prevention-oriented systems inherently address socially unjust policies. It might be one of the most important elements for advancing social justice, especially in our most vulnerable communities. Prevention-oriented systems lift up policies that alleviate disparities among those that have been historically oppressed, underserved, and marginalized. And they advance policies that reduce risk and promote prevention. This is, in some ways, having us put our money where our mouth is. These are all things we say we want, right? But now it's time to start to put some resources to it. You've heard these already. I'll do a quick recap. So there are 3 levels of prevention, right? And it's important to understand those levels and understand that they're preventing different things. Universal or primary prevention is preventing a problem before it happens. The aim is to prevent the problem for everyone, right? But we're rarely successful at reaching every young person, every family. Right? So in those cases, when we're unsuccessful in reaching everyone and primary prevention fails, we have to have secondary prevention strategies in place. And that's now preventing a problem among a group of people that are now at risk or have been identified at risk. So, and then when secondary prevention fails, we resort to our indicated or tertiary prevention strategies that we need to have in place. And these all need to be in place simultaneously. And now we're preventing significant problems for a group of people who are already showing some indication that they have some early stages of the problem. We borrowed these stages from public health. And so it's important to understand the different levels as we start to lay down the strategies and resources in our system, right? So universal or primary prevention is where you get the most return on your investment. It's where you get the most transformation. And to reflect back on our word cloud, the most overwhelming to put in place. But and then, conversely, tertiary prevention has the least ROI, is the most incremental and least transformational, and in some ways not as overwhelming. It's because you're serving fewer people. We in child welfare, at least, have anchored ourselves in tertiary prevention and then tried to walk backwards to see, well, what can we do to prevent? What could we do in the future to prevent what we're seeing today? My recommendation is that we pull up that anchor, and we're going to need the other systems to help us do it, but we pull up that anchor and set it back down in primary prevention, right? And then look forward instead of anchoring in tertiary and then looking back. The game with prevention, it's a, you know, it's not easy, but it's a pretty simple ratio when you look at it. The game is to mitigate risk factors. So what are those? Those are characteristics of an individual, a peer group, a family, a school, or a community that makes it more likely that a young person or a family will experience a problem. These factors place a person at risk or a family at risk for that problem. And these risks can accumulate. So if you have more risk factors, particularly over a longer period of time, that's going to increase your chances that negative outcomes will occur. They haven't occurred yet. They're risk factors. Some risk factors actually are connected to others and increase the likelihood that the problem may occur. And this is important because, so to speak, we can get more bang for our buck if we see how the risk factors are connected and address that cluster of risk factors. So what are examples of risk factors? We'll look to the substance abuse treatment realm. Well, risk factors are the availability of substances. If you've got the availability of substances around you, you're at higher risk for using them. Thinking that everyone uses substances is a risk factor. Not knowing how to refuse substances when they're offered are a risk factor. Or having a parent who abuses substances, that increases your risk. So that's one side of the game, mitigating risk factors. And on the next slide, we have the other half, which is increasing protective factors, right? So our game is to mitigate risk and increase protection. So protective factors are those that are going to make one less likely that you'll experience a certain problem. Or they might reduce a certain risk factor's impact when they co-occur. You can see them as buffers to risk, or sometimes protective factors are called assets, right? So think about when we talk about asset mapping, right? We're talking about mapping services or other institutional forms of support that protect communities, all right? And examples here, refusal skills. So knowing how to refuse, having, in that substance abuse example, no knowledge of the accurate social norms, showing parents how to monitor, after school programs, all increase protective factors against substance abuse. On the next slide, it's one of my favorite infographics that sort of show how protective factors sort of occur across the lifespan. It's from our friends at the Center for the Study of Social Policy. And on the left, we'll start on the left, 9 a.m., so to speak, on the circle. So those are protective factors that parents have that support their children's future well-being, right? So parental resilience, social connections a parent may have, knowledge of parenting, concrete supports, and the social and emotional competence of children, knowing how to address and enhance the social and emotional competence of children. As you move across the lifespan and you've successfully raised children into youth, the youth have their version of protective factors. And then as those youth move into becoming parents themselves, right, they can use those protective factors themselves for their children. Right, so protective factors occur across the lifespan, and they are, while they reflect each other, it's important to think of the parents in families with young children having protective factors, and then youth also. It is going to be overwhelming. It is going to be a lot of work. Why bother? Well, there actually are some significant cost savings from focusing on prevention. You heard some of those in Sacramento County's presentation yesterday, and they weren't theoretical savings. They were real savings. you can start to alleviate as you slowly reorient. It's not going to happen overnight, but alleviate the burden on already under-resourced systems of care. I mean, I work with many of you in my consulting practice, and everyone is suffering from being under-resourced, especially now after the pandemic. Be more cost efficient with your use of resources. You'll reduce eventually overall expenditures at institutional, local, state, and ultimately the federal level. The Administration for Children and Families understands this. That's why they passed Families First. There's reduced time spent by people in community level systems. And now we have more resources to address the more complex and severe and intractable problems that some families and youth may still end up facing. And then in general, you're going to have reduced operational costs in various systems of care. So it's an investment. And this is, reflecting back on my conversation about putting our money where our mouth is. The social determinants of health are a key organizing principle when you talk about prevention. And when one focuses on the social determinants of health, one focuses on equity. And we'll go into a little bit about how here in a moment. And now there are lots of models for social determinants of health. I want to acknowledge that. There's a 5 determinant model. There's a 6 determinant model. I've seen a 9 determinant model. We're going to use the CDC 5 determinant model. But it's all the same world. It's just chopped up into different sections depending on your theoretical background. All right. So what are those 5 social determinants of health? Healthcare access and quality, neighborhood and built environment, one's social and community context, economic stability, and education access and quality. And those of us lucky enough to be living lives of quality today, if you look back, these determinants of health were present for you and your family as you were growing up. So I'm a practitioner of implementation and an implementation scientist. So when someone asks me for help in implementing something, I ask what it is. Well, what is it that we're implementing? So when I've asked for help about, well, let's help implement a comprehensive prevention services program, what does one look like? I looked, and it was really hard for me to find a picture or a framework of a comprehensive prevention services program, like what it would look like actually on the ground. I mean, theoretically, I get primary prevention, secondary prevention, tertiary prevention. I get it, right? But what the heck does that look like on the ground in your county, my county? So I started to draw the picture myself. What you'll see on the next few slides is a table, not a picture, because I'm not a graphic artist. And we've got folks on my team working on creating a graphic out of it, but I think you'll get the picture. Now, remember, again, we're preventing different things at the different levels. And I'm starting at primary prevention because I want y'all to anchor there, okay? So what are we preventing with primary prevention? Well, you're preventing communities from becoming unhealthy. Right? So those are different strategies than preventing problems for people at risk. So if you use the social determinants of health, and the columns have different colors to reflect them, here's what that would look like to lay down strategies for primary prevention. So what are the service needs that a primary prevention system needs to address? Well, in the area of economic stability, cash support, job training and placement, food security, housing, childcare, right? And what does that look like what are the services we use to address those needs? We have child credits, we have food banks, we've got housing vouchers, we've got subsidized childcare. Right? So if you want to see if you've got primary prevention strategies laid down that support economic stability, got to map those. How do we do with regard to food bank? How do we do with regard to job placement programs? Do we have enough? Do they address the need? Right. Similarly in education, primary prevention needs, well, high school graduation, enrollment in higher education, literacy, early childhood education, parent education, and what services do we use to address those needs? We've got tutoring, GED support, career counseling, universal preschool, parenting classes, family resource centers. And watch, family resource centers are going to start to show up a whole lot across here, right? You get a lot of return for your investment in family resource centers, given they address a lot of service needs across the determinants of health. I'm not going to go through all of these or read all of these. You'll have them, but I think you'll get the picture. Stare at these for a moment. And so one of the things that you're going to need to start to ensure to create this comprehensive prevention services program is these things in black here. This is the most overwhelming. It's why we stay away from it. We throw up our hands. Well, these are poverty related, but it's where you get the most return for your investment. And it's what every community needs to be healthy. So if we're not working here, I ask myself, when I start to, anchor myself in tertiary and even secondary strategies, I start to ask myself, am I really interested in job security? Or am I really interested in having families not come to me at all as a social worker? All right. So what are we doing? Preventing unhealthy communities. So you could start working on this now, FFPSA or otherwise. Next slide. So now we're in secondary prevention. What might we add to that primary prevention system to have secondary strategies in place, which prevent harm for those now already at risk? They live in an unhealthy community. We missed it. We allowed that community to become unhealthy, and now folks are at risk of harm. What would we add? Well, you wouldn't add very much. Look at the items in red. Right? Again, the bulk of the work is in the primary area. But you'd add things like wraparound services or home visiting as secondary strategies. You'd add things like baby wellness clinics. You'd add domestic violence services. Now, because we all know in unhealthy communities, there's a lot of toxic stress and the risk of family violence goes up. Crisis lines, respite care. Now you need mental and behavioral health support. Right? So you'd add those parent partners. Those are strategies you'd add to that primary prevention system. So now you have secondary strategies also. Right? And the next slide, tertiary, what might you add to this? So now you have tertiary strategies also in place, right? When you get to tertiary prevention, harm has already occurred, right? For those at risk, for some of them, harm occurred. So now you're in the game of preventing future harm. So the recurrence of maltreatment, if we're talking in the world of child maltreatment. So what would you add to that system? Well, you'd add things like our traditional 4-H child welfare services, support for medically fragile folks. You'd add adoption support, CSEC programming, forensic hubs. Right? Those are what you'd add. But you can start to see these secondary and tertiary strategies. They're easier, right? There's fewer of them. There's fewer folks. So we tend to put all our work there, and we tend to have our agencies that are the usual suspects, right? The departments of mental health, Department of Child Welfare, child welfare departments, and our probation departments. We put the onus on them. Primary prevention. By the time they get to child welfare, you're undoing harm, and the outcomes aren't real great. So this showed me, when I started to lay this down, this showed me that it can't just be child welfare, probation, mental health. Where's public health? Where are the public libraries? Where's Parks and Rec? Where are the neighborhood councils? We're going to need all those folks at the table from the beginning, not just when the agenda calls for it, from the beginning, because those of us in child welfare, probation, and DMH, we're used to tinkering on the secondary and tertiary edges for the most part. We need help from the agencies that are anchored in primary prevention. If you stay anchored in the social determinants of health, you will automatically default or orient toward primary prevention, which is the bulk of the work. And so as I was creating this table, I started to look at all the funding that might be available. I started, of course, my field is child welfare. So I started looking at the child welfare funding sources, right? And you can see those across the top in each determinant of health. And I'll tell you what the gray column that just showed up is. The gray column is funding that supports the creation of infrastructure, right, to support these strategies. And then there's other funding that we can braid in. So in our economic stability social determinant of health, which is the peach salmon color, you could say, you can see there's CalFresh, there's CalWorks, there's family stabilization funding. And this is not an exhaustive list, but it can't just be child welfare funding. We've got to figure out what the other funding sources are and bring them into the fold and have them understand, wait, you are just part of a larger comprehensive prevention services planning system, right? Across the middle row there, our rubric still applies, right? When you're dealing with primary prevention, who are you serving? Well, you're serving in the economic stability realm, the general population, all youth, all families raising children. But when you start to get into secondary strategies, you're going to have strategies in place for low socioeconomic status families or homeless families or CSEC youth for the tertiary strategies. Similarly, in the education, the second column, primary, you need services for all students, strategies, public awareness strategies, perhaps, for all professionals that serve them. But then you need secondary strategies in place for the students and communities that didn't benefit from primary strategies and their students at risk for academic underachievement. Tertiary strategies, you need those for students experiencing a life crisis or have developed chronic problem behaviors, those that are going to suspend it, those that are getting expelled, right? So on and so forth. And then in the last row there, I looked at the evidence-based practices that are in our current 5-year plan that we are in the process of negotiating and iterating with the Administration for Children and Families. Those are the evidence-based practices that have been reflected, and they fall right in to the social determinants of health. So, if there were one thing to take away from these 3 slides is use the social determinants of health as your organizing principle. If you start to use the agencies themselves, we're just going to re-anchor in tertiary places. So now, next slide. Now that we've got an idea of what this comprehensive prevention services system is going to look like, now we can ask ourselves the question, well, how does FFPSA fit into this? Right, so let's change gears and turn our attention to FFPSA. FFPSA does allow us to slowly reorient our system in support of a comprehensive prevention services program, but it's not the program itself, right? FFPSA's focus is those at imminent risk and those at imminent risk of foster care, of something very specific. Now, we have been encouraged to go as upstream as we can afford to go, as far as we can get away with. because there's a lot of research that shows that the risk of foster care is imminent when secondary strategies fail, and maybe even some primary strategies. We've got enough longitudinal research to prove that. So yes, FFPSA can support going upstream, but FFPSA can't do it alone. So the question to ask is, how can we use the 4E entitlement that FFPSA is going to make available to us for prevention to boost the entire continuum that we just looked at, right? And again, here, just a shout out to Hillary and all the folks at the Office of Child Abuse Prevention. I learned a lot from all of you over the last couple of years, and this infographic comes from their materials. What are significant problems families face when communities aren't healthy? Substance use, delinquency, family violence, mental health challenges. These sound familiar? These are the very categories of services that Family First Prevention Services Acts funds, right? So you can hear secondary and tertiary prevention. Right? So that's how this starts to connect up. So just a quick refresher on FFPSA. Some of you may have seen some of these slides at a summit we did almost a year and a half ago now. There's actually 7 parts, but there's 2 parts that impact us the most day to day, those of us on this call. The prevention services, part 1, which is what we're going to focus which is the focus of these 3 days and of this presentation, but also part 4 is, you want to acknowledge that part 4 is something that folks are working on. But when you're talking to your jurisdictions, if you say, well, we're working on FFPSA, you have to say which part, because they're very different strategies. These 2 key parts fit together. Right? So if you start at the top of the circle, right, you have prevention services that hopefully prevent entry into the foster care system, right? If they don't, then we need to have a way to assess well and ensure appropriate placements, which is where part 4 come in. If we did that, and did that in a way that adheres to the research that shows what works with regard to STRTP models, all our new strategies around group homes of 1 or intensive services foster care, right? If we do that correctly, short-term, time-limited, intensively, then we would hope that that children would be reunified or adopted or have guardianship with permanent families. Well, those families live where? In communities, right? They would access further prevention services so we can prevent re-entry into the foster care system. So the re-entry population, or population at risk of re-entry, is a key candidate when it comes to prevention services. FFPSA was passed in 2018, which is 4 years ago. It's hard to imagine. And it went into effect in October of 2019. The big selling point was that it now includes prevention services in the Title 4E entitlement, while still retaining the entitlement for foster care, right? We can now use 4E for prevention services, for services to families before the hotline. Okay. Next slide. Just some key properties of FFPSA. It's for families of children, again, who without these services, you can justify would enter foster care, plus pregnant and parenting foster youth, who are categorically eligible, but that doesn't mean they're categorically at risk. We need to be careful about just presuming that a pregnant and parenting foster youth is just automatically at risk for having their children be in foster care. It's a pretty damaging assumption. We all know the research, but it's still a pretty damaging assumption when it comes to human being. It's available to candidates. That's what the federal government calls them, candidates for foster care. They may not make it there, but they could. Candidates can't just be known to child welfare. They also have to be proven to be at imminent risk for placement. FFPSA is not, it's not the Families First Prevention of Child Maltreatment Act. It's the Families First Prevention of Foster Care Act. It's placement prevention. It's not maltreatment prevention, right? So again, you start to see where in our system these services are targeted. Available for up to 12 months per family per episode, and there are mechanisms in place to provide more services as needed, and they are optional for states. And when we talk further on the 29th, you'll get information about that event. We'll give folks a little update on how the other states are doing. Who are going to be our candidates? So what's the menu of candidates available for you and your county to choose from to serve? Right. So these are the candidacy categories that are currently in the plan that Cheryl and Cheryl's team is working on. So these are families receiving voluntary or court-ordered family maintenance, so volunteer or court-ordered family maintenance services, so VFM-FM, probation youth, subject to petition under 602, children whose guardianship or adoption arrangements are at risk. So those are our children at risk of reentry, I mentioned before. Children with a substantiated or inconclusive disposition of child abuse or neglect, but no case opened. Children who have siblings in foster care, but not categorically, have siblings in foster care and who are determined to be at imminent risk. Homeless or runaway youth, LGBTQ, not categorically again, but LGBTQ youth proven to be at risk, substance exposed newborns, trafficked children and youth, and you can see these are some of these categories overlap, like trafficked youth, homeless youth, and LGBTQ youth, children exposed to domestic violence, and children whose caretaker experienced substance abuse disorder. And then there's this sentence in the plan, which is generally it's any children or youth, including tribal youth or pregnant and parenting foster youth, experiencing serious risk factors that when combined with family instability or safety threats would be assessed to be at imminent risk, and assessed how? According to some assessment tool that contains the state approved elements. So it doesn't need to be a particular tool. The state isn't prescribing use tool X, it's prescribing elements, and your assessment tools need to contain them or be modified to contain them. For FFPSA funding, what services are we going to use to serve candidates? Again, this is nothing about those services in black, the primary prevention services. But here's what FFPSA prevention services can be used for. They have to be used for trauma-informed mental health services. That can include individual and family therapy, substance abuse services, and in-home parenting skill-based programs such as parent training or home visiting. That's the tableau of services available for FFPSA funding. The services that we can use have to meet a level of evidence, okay? And who gets to say which services meet the level, the appropriate level of evidence? The federal Title IV Prevention Services Clearinghouse. So when you see PSC, that's what people are talking about. They're talking about the Prevention Services Clearinghouse. And there's 3 levels that are allowed for now. The date seems to be changing a bit, but by either 2024 or 2025, all of our services need to be, 50% of the prevention services claimed for FFP must be well supported. But till then, we can have promising, supported, and well supported as for the Prevention Services Clearinghouse. And all that means in terms of the level of evidence is that well supported studies have 2 or more studies peer-reviewed studies that have random control groups that said that this service works. Supported strategies only had one RCT, or randomized controlled trial. And promising practices, they did have a study with a comparison group, at least one, but it wasn't randomized, which means we didn't randomly say, oh, you get the service and then the next child or family doesn't get the service or gets something else. It wasn't random. So that's what those levels of evidence mean. Next slide. And it's going to be up to us to look at that menu and match the needs of the families that you all serve, right, to those evidence-based practices. We've got to take cultural responsiveness into account. We're going to have to take feasibility of implementation into account. I mean, if you're already doing some, might want to keep those, focus on those. And you do want to think about those that create the least evaluation or cost burden. The well-supported practices, well, because they've been proven to create those outcomes, you can waive an evaluation, doing an evaluation for those. But if you use supported or promising evidence-based practices, then the federal government requires that you have a concurrent evaluation happening to prove that those services are actually getting you the outcomes that you want for your population, right? So for now, these are California's selected evidence-based practices. Okay. They all happen to be well supported. So for now, there's no evaluation burden on any of us if we select these. I say for now because there are more and more practices that are becoming well supported as time goes on with the clearinghouse, and B, the state may add based on some of the data that we're seeing as time goes on with amendments. And for now, here's the menu. Next slide. So how are we going to pay for it all? Well, you're going to have to braid funding. And these next 3 slides we'll go over in way more detail in a future learning series. But I just want you to take a look. Go ahead to the next slide. There's plenty of funding that can be braided. It's gonna take some creativity and tapping subject matter experts in the financing area. So this page actually represents new funding that's available to fund those services. So your FFTA transition grants, that can be used. There's a state block grant we're going to go into in a little more detail. There are ARPA CB-CAP funds. And then there are existing 4E funds that can be used. But those are down the road. And I'll tell you what I mean by down the road in a moment. All right. So these are new funding streams. The next page, and these are existing funding streams that you might be able to bring to bear. Okay. Again, not an exhaustive list, and only looking at secondary and tertiary for the most part. In the other table, I showed you there's a lot more funding outside of child welfare that can be used, and you may want to start tapping those agencies and start to get them oriented to their role in comprehensive prevention. Again, these are also existing funds, CAPTA, ARPA CAPTA, State Children's Trust Fund, or CB-CAP grants, all available to be used. All right. So next slide. There's some key funding issues that are posed by FFPSA. One is, well, you are going to have to come up with a match, right, to use 4E services. Right? So we're going to figure out where that comes from. There's the mandate of maintenance of effort, which means that FFPSA funds cannot supplant current efforts with regard to prevention. It can get tricky because, well, they can't supplant practices that are being provided currently with fidelity. So there's an argument to be made. Well, if we weren't providing them with fidelity, then could we use FFPSA fundings to get us there? And that argument, folks are still arguing that one. And then payer of last resort. Child welfare 4E funds have to be the payer of last resort, which means that if Medi-Cal, for example, could pay for this service at this time for this child, then Medi-Cal should pay for it. Conversely, what that means that if Medi-Cal or some other funding stream is not paying for this service for this child at this time, then child welfare funding or 4E FFPSA funding can be used. And that's a mantra. I'll say it again because it really keeps me straight when I start to get confused, which can happen very quickly when it comes to FFPSA. So can we pay for this service for this child at this time? If not, right, for capacity reasons, for geographic reasons, then we can use 4E funds for it. Big takeaway here, this is going to take a while to be able to draw down FFPSA funding to fund prevention services, right? And in my experience, it's become this red herring where we're all worried about FFPSA and how are we going to claim FFPSA? There's plenty of work to do till we figure out some of these FFPSA issues, and there's plenty of other funding to be used to support the building of these comprehensive prevention services programs. So the key funding issues I just talked about on the prior slide. Then there's automation contingencies, right? We're in the midst of an overhaul of our SACWIS system, going from CWS CMS to CARES. That's going to take a moment, at least into 2023. Then claiming structures have to be built. There have to be rate negotiations around these evidence-based practices. And then we've got to build CQI systems that integrate with our current CQI systems that monitor these EVPs, child-specific service delivery, and fidelity monitoring, right? This is all going to take a while. In the meantime, right, think about using state block grant to start to lay down some of the strategies. Don't use, it's easy to throw your hands up and use FFPSA as an excuse to wait. But you don't have to. Next slide. So what's required to get at this state block grant? And to the tune of your share, depending on allocation methodologies that we use now, of $222 million. Okay, it's not insignificant. So how do you get at it? If you wanted to get at it before January of 2023, you submitted an LOI or a letter of intent that was due April 30th. Extensions have been made on a case-by-case basis. So if you haven't submitted one, it's worth asking. If this presentation and the presentations of these last few days have a sort of a bell go off that it might be a good idea to turn the spigot on early, right? So there's a letter of intent, really short form, to get the spigot turned on early. And then the confirmation of your intent comes in January 2023 when you submit a 3-year comprehensive prevention plan, or a CPP, that has primary, secondary, and tertiary services and strategies, which hopefully are already in development, what your 4E service strategy is going to be, how what you're doing is culturally appropriate and responsive, to your local populations, particularly your Native American and Alaska Native families, families of color, disproportionately represented in systems, LGBTQ children and youth. All right, so you'll have to say, and then as of now, services are potentially claimable retroactive to October 2021. What are the elements? The LOI form is short. The 3-year CPP, or the Comprehensive Prevention Plan, will take some work. Okay, what are the elements of it? And you don't have the state will provide a template for it to use if you want, right? But you don't have to use, just like you didn't have to use a state-approved assessment tool. You just have to have your tool reflect elements. It's the same concept here. As long as these elements are reflected in your CPP, you can use whichever template you'd like. I know some of you have already hired consultants. They may have templates that you want to use. That's fine. So what are some of these elements? Well, outcomes of asset mapping and local needs assessments, or capacity and readiness assessments if you're going to do them. Those capacity and readiness assessments are not mandatory, but the outcomes of asset mapping, some asset mapping and needs assessment are. What your rationale is for your candidacy and service array choices. So with those two read, you're going to have to, and reflect back to Paul Collier's presentation yesterday, right? You're going to have to look at data to come up with those. You're going to have to describe how you're going to govern this comprehensive prevention services program, right? You heard Michelle yesterday talking about using their prevention cabinet. It's one strategy. Some of you may need to come up with a completely new governance approach, but it's a governance approach that has to include cross-sector collaboration. And I hope after this presentation, we don't continue to see the usual suspects at the table. That we do start to have public health and other agencies at the table with this cross-sector collaboration, or you're not going to be able to pull off this reorientation. You're not going to be able to get those cost savings. You have to describe particularly your efforts to engage tribes on the ground. And then all that will tell you what your theory of change and your logic model are for your comprehensive prevention services program with the primary, secondary, and tertiary strategies. Right? Then the other elements are sort of more assurances for the long term, like assurances that you will do training as the guidance on training gets released, assurances that you will do CQI and model fidelity, assurances that you will do risk assessments and safety monitoring. You don't have to know exactly how that all has to work to submit the CPP. You just have to provide an assurance that as the guidance gets released, as the federal government approves our plans, that we will adhere to those, to that guidance. Strategies for use of the integrated core practice model, and how that's going to apply to 4E funded prevention services, right? I mean, we are adding essentially an additional leg to your child welfare case arc, right? It used to start at hotline. It can start before now. How does the ICPM apply there? What your spending plan is going to be? This is a key one. How you're going to coordinate with mental health around the service array, and what your sustainability plan is. It's not a sustainability promise, it's a sustainability plan, but we all learn from the 4E waiver experience, right? That if you don't start thinking about it now, the cliff is high when the funding runs out in 3 years. All right, so those are the elements of the 3-year CPP that you have to do by January 2023. But you can get started on it now and get funding early by submitting, and those of you that submitted an LOI, to work on it. Aspects, these are in the block grant. You'll have this presentation. So what can you use the block grant for? Delivery of evidence-based practices. You can use it for any prevention services that are not evidence-based, as long as they're sustainable beyond the 3 years. You can use it to support administrative costs, to support prevention service delivery. You can use it to pilot EBPs, or to support the establishment of infrastructure to do your model fidelity. You can use it for administrative activities like your implementation readiness work, your gap analyses, your asset mapping, your readiness assessments or capacity assessments if you're going to do them. Right? You can use the block grant for all this. Next. You can use it for delivery of direct services beyond those that are in the state's 5-year plan. And many of you have been part of the stakeholder review for those over time. You can use it to support evaluations. You can use it to support primary strategies, right? Public awareness campaigns. Hey, those are primary prevention strategies. You can use it for training and workforce development on EBPs or otherwise. Okay, you can use it for raising the level of evidence on practices that you want to see in the 4E Prevention Services Clearinghouse. You can use, the big takeaway is you can use the block grant to get ready to deliver FFPSA funded services down the road. Okay. But before you work on being ready to deliver a service to your first family or first child, there's some capacity building you need to do. All right. And this can keep you busy while we work out the plan with the federal government, while the developers work on the care system. What are those activities that are going to build your capacity before you can even work on readiness? And these are going to help you write your plan. Well, in partnership with your other local agencies, a local scan, right? You can call it your asset map. You can call it a service inventory. But it's a scan of all your EBPs that you're currently providing. You have your arms around that right now. All your waiver and non-waiver funded prevention services that exist that are not EBPs. And this scan should include each service and each service's funding source, which includes the agency that's the pass-through for the funding and the funding stream itself, the cost of delivering the service, the outcomes, both engagement outcomes, like are people actually going to these services? Are they completing? And then are they getting the life outcomes? Where are these services? What's the current capacity we have for these services? And what's utilization like? You can imagine that creating that matrix alone is a fair bit of work before you can think about delivering F4E funded services. Okay. So you could get working on that now. Then you're going to need to create estimates. And you could use many of the strategies that Paul talked about yesterday to figure out, how many families and children do we have that have substance abuse needs, mental health needs, or parenting needs within each candidacy group? And where are they? Right. Then you've got to match your services to who you have and what they need. And some gaps are going to emerge. Right. And then you can set in place strategies to fill those gaps. More additional contracts, expansion of current service delivery contracts, creation of more FRCs, the CAPC system. Where do we now need to put resources given where our gaps are? But you're not going to know till you do your entire service inventory and you look at all your data on your populations that are at risk. Right. And then at least identify a cross-sector oversight body for this prevention services and agree to it. And that has to have, underline, a way to engage those with lived experience and those disproportionately represented in the system, particularly our tribal families. Okay? So these 4 things is plenty of work, and it's work that you can start now based on what we've provided you in these 3 days and with the technical assistance already available. Right? Like, don't worry about FFPSA claiming. There's plenty of work to do right now without worrying about that. Once you do all that, we're just going to do a brief nod to then what's the readiness work look like, and we're going to go into these areas in depth over the next few months in a learning series that we'll share with you here in a moment. But what are all the tracks of readiness? Governance, cross-sector collaboration, fiscal and funding, your program design, which is your comprehensive prevention services program design and service array. These 4 you'll already have started work on as part of capacity building and writing your CPP. To start a little later will be, how are you going to deal with your service quality measurement and outcomes? How are you going to do your workforce development training? How are you going to upgrade, create, or update your policy, rules, and regulations to add prevention? How are you going to do all the reporting that's required? And what's automation going to look like? What's your local interface going to look like for automation? Okay, so you can imagine these as tracks, some of them starting sooner than others, but ultimately all having to be coordinated. So we'll just run through them briefly so you understand what I mean when I say get ready with regard to governance. So governance, which is this, another fancy word for like, who's your strategic on the ground steering body that's going to allocate resources, bust barriers when it comes to your comprehensive prevention services program, which has all 3 primary, secondary, and tertiary strategies. So once you've identified the structure, right, then how's that structure going to make its decisions? What are the different roles and responsibilities of the peoples present? What are the data sharing agreements, if any, are needed? What are the stakeholder engagement strategies? You're going to have to start to develop charters and memoranda of understanding and a communication strategy that keeps your communities apprised of how this development of prevention is going. Right? Those are all readiness activities with regard to that governance structure that you've identified as you develop your capacity. Stakeholder collaboration. Again, you've already started on this because you had to write your plan. Engaging ongoingly folks with lived expertise. What are the actual, are they coming to you or are you going to them, right? How are you going to ensure or develop ethnic and cultural responsiveness in your existing service array? How are you going to communicate to your stakeholders regularly? How are you going to integrate service providers into the development of the model? Fiscal and funding, well, what exactly are you going to use and how are you going to track the use of your transition grants for those of you that got those, your FFTA funds? What are your cost models going to look like with regard to that gap analysis that you are now going to have to implement? What's the budget? What's the contracting implications of your gap analysis? How are you going to use your block grant strategically? How are you going to negotiate rates for EBPs with the purveyors themselves or with your mental health plan? How are you going to deal with those key issues around match, pair of last resort, and maintenance of effort on the ground? State has to deal with them at the state's level, but you're also going to have to deal with your local version of these considerations. And then as the guidance starts to get released, what are the no kidding accounting, claiming, and reimbursement processes, actual money moving that's going to have to happen that ultimately provides services to families? Your program design and service array. Do you have a vision and mission written down? Again, these are, with this one, this is another one that you'll already be at work on when you write your CPP. What is the service array going to be? What's the current one? And what does the future service array look like? Are you going to elect to do a community pathway? Which means our service is going to be available to those families identified by service providers. not just by child welfare. Ongoingly, I mean, you're going to submit, you're going to have to figure out which template do you want to use for your plan. How are you going to, how are you going to make sure your steering body reviews the developing plan? What are those review cycles? If you don't plan for that, we all know how long that stuff can take. And then what's your plan for updating your plan as the state updates its? Again, this is all going to start further down the road. But you are going to have to figure out, okay, I have an existing CQI system. Model EBPs haven't been part of it for the most part. How am I going to put EBPs in there? What metrics? Purveyors sometimes give you choices with regard to outcomes and model fidelity. Am I going to use this metric or that metric? Which tools am I going to use? How am I going to aggregate and communicate outcomes and results of the overall program and of the different EBPs, right? There might be a future statewide outcome evaluation. And if there is, how might we participate in that? You're going to have to develop a training framework and an overall plan for training. This is not insignificant. Providers, folks that do contracts, and you're going to have to develop curriculum on case management. Like how are you going to do casework differently with regard to prevention? Are you going to have your own unit that does prevention, or is everybody going to do prevention, for example? That's one of those considerations. How are you going to modify and upgrade the practice model to integrate prevention? And EBP training, evidence-based practice training, practitioners have to be certified or licensed to provide these practices, and you have to monitor and track that they're still current. Those licenses and certifications. You got to provide that training. You're going to have to do a policy scan. How you do caseload assignment may change, and you're going to have to reflect that in policy. How you do training and supervision might change, particularly if you have a community pathway. That's got to make it into policy. How are you going to communicate all these revisions or addition of new policy, right? And who's going to keep track of what future policy modifications or needs are going to be required? Do you have the bandwidth, or are you going to have to develop the bandwidth on the ground in your policy shops to do that? Reporting, there's going to be federal reporting that the state has to do. There's going to be local reporting that the state's going to require review. There's going to be local reporting that the purveyors of the EBPs are going to require of you. There's claiming that's going to have to be done. There's reporting and claiming that's child-specific and not child-specific. There's going to be guidance on data elements that you're going to get and then have to communicate, then customize locally and provide forward to your data shops. Feedback loops have to be put in place. How do your reports actually make their way back to your governance structure? And how are you going to communicate results and outcomes to your stakeholders and your communities? Last but not least, we are going to have to figure out, with regard to CARES, all the different data entry roles. Is training going to be reflected? Training or certification be reflected in CARES? What reports is CARES going to have to spit out? What CQI data can CARES address? And then locally, and I know you all are in conversation now with the CARES development at the state level, but you're going to have to, that's all going to all have to apply to prevention too. Like I said, in future sessions, we'll be going through these areas and the how-tos. This is the how-to. But before you have to worry about all that, right? I just wanted to, it's not to overwhelm you, but it's just so you don't underestimate the work ahead, right? But that said, worry about your local service scans, worry about looking at your data and figuring out strategically who you want to serve over time. Worry about figuring out what that governance structure is going to be. Talk to your prevention cabinets, talk to your 2083 ILTs. I don't know if you have other local structures, right? You work on those 4 things. That'll keep you plenty busy as some of this reporting automation and CQI stuff starts to develop.
So I just want to address a few questions I've seen a few times in the chat, and that is that the slides and the presentation we will upload to YouTube will be available later. We will email everyone. So just so you know, I think there was a ton. I just wanted to give you your flowers, Kush, because tons and tons of folks were feeling like the information you gave really helped connect the funding and just the planning in a very concrete way for them. So I just wanted to acknowledge that before we went too far into the Q&A.
You're all very welcome. If I can make this a little easier for y'all, it's worth it, because ultimately you're going to keep my LGBTQ youth out the system.
I love that. And actually, I will say, I was like, bing, bing for myself. I'm like, I need Kush on speed dial.
Well, that might happen here shortly.
So Shelly from San Francisco would like to ask a question. So Shelly, I'm going to unmute you.
I was wondering if you had any ideas for how to set up goals or outcomes in the primary prevention areas, because I think one of the things about primary prevention, as we all know, is it's more difficult to, like, there's not like necessarily a direct one-on-one. Like if you have a tertiary counseling thing, you can tell, like, oh, the kid got reunified with its parents, with their parents, yay, right? But there's less of a kind of one-to-one correlation. So I was wondering if you had any ideas for how to set up primary prevention goals that are meaningful and also reflective of the kind of length of time needed to see those positive effects.
It's going to take months or years to start to realize, to see if needles have moved on the community level, right? But so that's where things like the Casey Community Opportunity Map come in, right? Folks have researched what to look at to see if communities are healthy, right? So community health outcomes is where there is to look. So go find public health, right? And ask them, what community level outcomes are they looking at, right? Could they join you? Or could you join them? But it's all community level outcomes. So the community opportunity map is the first place I'd have you go, because it's a vetted source. But there was a whole bunch of stuff in that data playbook. If that one doesn't work for you, I know LA has its own score. Like the Office of Child Protection has been working for a long time on a map of what community level outcomes to look at. Just go, but it's going to have to be community level outcomes. And you don't need to look at 20, right? You can be strategic. You might pick 3 to 5 and say, okay, together, public health, child welfare, mental health, let's get together and see if we're moving the needle. There's place-based strategies. So, examples are things like Magnolia Place in LA, right? You can start to look at those in certain strategic communities, right? To have it be. So what zip codes and what census tracts do you want to focus on with those 3 to 5 outcomes, right? So keep it manageable. And there's for those measures, there's some pretty decent historical data. And there's where do you go to find benchmarks? Well, you can go to other communities and see, how communities that are doing well, and have those be your targets. You can have your targets be better than you were before, right? That's historic, from your own historical performance, right? And if there aren't benchmarks, you're going to have to sit with your steering group and say, okay, well, right now this is at 10%, and we all agree that that's awful, right? Can we get to 15% in a year, right? The other thing you have to keep in mind is you have to have regular time intervals already planned for where you're going to look again, right? Because are we going to look at this now, and then we'll look again in 6 months, and then we'll look 6 months from there? or do some of these community factors need longer looks? Like nothing's going to change for a year. So, but plan that now, because and have somebody remind you to look, because folks forget, right? We think, what disproportionality? Well, yeah, okay, but those were your numbers last year. What are your numbers this year?
So much. Thank you, Shelley, for the question. Next, I'm going to unmute Amy Jaffe from LA.
I did just want to gently push back a little bit on the piece around, like, don't worry about claiming, don't worry about automation. I hear that, but I also really worry, like, this block grant's only good for a certain amount of time, and we need to be able to do some small, like, PDSAs to go, like, okay, is this really going to work the way we think it is? And I think we need to plan for iteration. And so, to me, like, having claiming and automation be part of the early conversations allows us, while we're still kind of, parallel processing, like, the big picture. So I just kind of wanted to put that out there. And
that's a great point.
And just see, like, if you had any, like, maybe thoughts or recommendations around, like, where we might start with some small PDSAs. We have some ideas, we have some conversations. I know a lot of folks talked about, first 5 and then home visiting, and that's where we're really kind of starting to think about it. But again, like, we get a little bit and then we kind of get stuck on this claiming automation thing.
I mean, one place you could start to do your small tests is in the sort of CQI realm and the model fidelity realm. And, to acknowledge, I mean, there are, LA was, one of the original waiver counties, right? And have been working on this for a while. So, so those of you that sort of just got here to the prevention conversation, right? You're like, don't worry, right? They have a head start. So that's right now, that's sort of in your control, right? Like I'm a little above my pay grade when it comes to claiming and automation, and Cheryl's folks can speak to sort of how that's all going to go the best. However, are you delivering all your services with model fidelity? And what would it take to start to, if you're not, right? And not that you think you are, but you can prove you are, and where you can't prove, what's that going to look like? Do you want to use this tool or that tool? Right? That's the area in which I think particularly LA could play and really actually contribute something to the rest of the state.
I'm going to go to Michael Williams.
Hey, thanks for that, Kush. That even for us working in this, it really helped tie things together a lot. I wanted to speak to what Shelley brought up around selecting primary prevention, just in terms of the work that Strategies has been doing. And I think what you were talking about is really consistent with this. Within that discussion you described, I think what gives focus to that is giving attention to your theory of change. And that is sometimes for some folks, that's like, okay, we have to check that box, but that really is working with your group to think through what is driving the change we want to create in our community. What are the major factors leading to child abuse and neglect in our community that are the most salient? And then work we've done with counties, once that's clear, is with those factors, let's do some assessment within our collaborative of what's our readiness to do something about it, and what's the potential impact of some strategy ideas to go after that. And that's going to help narrow down, like you said, those few things you want to focus on.
I've worked in the field a long time. I've brokered, demonstration projects between providers and the mental health side of the house and the child welfare side of the house. And however you all partner at the county level is how it's going to look at the provider level. Right. So, I mean, I don't know what representation we have here from behavioral health or from public health. but those fractures, right? And I mean, it goes up from the state all the way down. Those fractures ultimately fracture your provider community, and then they fracture services to children and families. Okay. So I want to make that point. And then to just piggyback on Michael on what you said. Okay. Social, anchoring in the social determinants of health isn't like a nice to have. Like primary prevention isn't a nice to have. Let's all hearken back to that shooting in Buffalo. Not to be a downer, but there was one grocery store, one. And those folks were sitting ducks. Okay? That's what happens. That's what happens when you neglect primary prevention. And then we all wring our hands. We all send thoughts and prayers, right? How many grocery stores do you have in the ghettoized communities, right? Who's working on that? All right. So just, it's a harsh thing to say in some ways, right? But this stuff is a matter of life and death.
Earlier in the chat, I know there was some discussion about the importance of including the first 5 commissions into the planning. And I just wanted to know if you wanted just to comment on that or if you had any thoughts around that.
I'd be running, not walking, to go partner with them. They've been working on evidence-based practices. They've been working on model fidelity monitoring. They have funding. They understand primary prevention. Yeah, so run, don't walk is how I would answer that question.
Well, thank you so much, Kush. I think your presentation really put everything into perspective, gave some very concrete ways that the funding connects to these different levels of prevention. And I know that there was a lot of people in the chat that were just really sort of reiterating how helpful it is for them.
Hi there. I'm Lola Cornish. I am the Senior Program Manager for Strategies Technical Assistance at the Child Abuse Prevention Center, and Sarah Lacroix, my counterpart at the Children's Bureau in Southern California. And I will be talking a little bit about the technical assistance support that's going to be made available to counties in the near future. So just a little bit about Strategies TA. If you were with us on the first day, you heard Troy Nichols talking about us and the work that we've been doing in partnership with the Office of Child Abuse Prevention and others in the past couple of years. The first thing I want to point out really is our values, which we try to live. We have action statements for each of these values related to the work that we do out in the community, as well as the work that we do internally. And those values, obviously, equity is huge, making sure that the community voice is included. We can't really get to equity if we're not focusing on community. And thank you, Kush, for your fabulous presentation that highlighted the social determinants of health and their role in equity as well. Strengths-based processes, accountability to those we serve and to ourselves, and collaboration, of course. So we've been doing this work of supporting and inspiring cross-sector collaboratives for a couple of years now. And our role is really centered in that equity and inclusion and community voice piece. We work with primarily child welfare and child abuse prevention councils in 29 counties throughout California, consulting in a variety of different areas. It may be providing subject matter expertise, or the basics, product development, like agenda development, things like that. And it goes as far as leadership coaching and facilitation skills training. And we've been supporting counties to work toward the development of comprehensive evidence-based child abuse prevention plans. So you saw this yesterday. I believe Hillary talked about this slide, which is really an overview of the process of developing a comprehensive plan and figuring out how to implement it. And, just like preventing child maltreatment cannot be just child welfare's job, the technical assistance that's going to be needed in this arena takes more than one provider. And so we're going to be talking through those pieces soon. But you can see the roadmap for comprehensive planning and implementation here. And the technical support that will be provided will be designated through the Department of Social Services. And we're going to talk a little bit more about what will be available to the prevention planning teams next.
So good morning, everyone. So nice to have you here and happy Friday. So I'm going to talk a little bit about sort of the current resources that are available to folks for developing their comprehensive plan, because as we know, time is of the essence. And for many of the county teams that Lola mentioned, give or take 29 teams we've been working with, there are some tools, resources, and processes that we have utilized more frequently that we have found to be helpful. And for the most part, those are tools and resources that are already available. You know, they're non-proprietary for public use from a variety of different trusted sources. So just kind of referencing back, I believe Hillary mentioned this on Monday, and I know not everybody was in the pre-institute. Strategies has been working in partnership with CDSS to develop a toolkit and also the accompanying template that will be sort of the actual, what people actually in their comprehensive prevention plan into for submission. So we have had to turn that around quickly, and we do know that the toolkit will be made available, and we're hoping in the next few weeks. It does have to go through the full review process with CDSS. But as I mentioned, a lot of the tools that we're connected to and come out of the toolkit have been vetted by us in doing this work, and also in conjunction with other partners, right? So, you know, one really incredibly source of helpful support and information has been with the Child Welfare Directors Association Child and Family Enrichment Cabinet, which is inclusive of a lot of the prevention planning teams we're actively supporting and working with. And so a lot of times we've been able to kind of come back to that cabinet and say, what about this? Is this useful? What do people think of these tools? And I've gotten some really great feedback. So I know a few of those folks are on here today. So just a shout out to you and an appreciation for that feedback you have given us, which did help to inform some of the tools that we released in the draft of the toolkit that ultimately will come out hopefully in the next few weeks. So what I'm going to do to kind of get folks started, because one of the things we do hear so frequently is that folks want tangible things they can use right now, right? And so I'm going to go ahead and screen share first the strategies website. And I'm not going to run through this in each section by any means, but just sort of give you an overall orientation to it and then show you two tools that, for example, you could access now through this, the toolkit resources. So this is our strategies website here. And so you'll see our mission statement as it comes up front. So what you'll do when you get onto the strategy site is you can go to the Comprehensive Prevention Plan Toolkit. Again, this is not the full toolkit, but instead the resources, some of the resources we've utilized and recommend that are not proprietary and are for public use. So when you get into this page, and I'll just kind of give a little disclaimer, this is constantly being updated and revised. New tools are always coming out. Our team is constantly troubleshooting different things, trying different things. You know, I believe Amy from LA mentioned the PDSA process, right? We are always learning, always in revision. So just know that this will be continuously updated as the work moves forward. You will see though that the planning toolkit page here is broken up into, for the most part, the table of contents of the toolkit. Again, which is no surprise, it is based off of the all county letter that came out, the state block grant letter. So you'll see the capacity and readiness information is here. Folks can, if they like, submit that capacity and that capacity assessment online. I'm not going to click on it. You can do it down. You can download it as well, but you can do the capacity assessment virtually. The readiness assessment will be coming out shortly, but for now we have some resources from the Capacity Center for States around change and implementation and practice, thinking about readiness. So the sort of toolkit is broken up into two, I would say, main sections. The one being the cross-sector collaborative, strategic direction, focused on systems change. And within that, you'll see, so within this heading, you'll see the section 1 here, developing and utilizing that cross-sector collaborative approach. And you'll see all the pieces that come under that with the resources connected. You'll go down to governance and infrastructure, mission, vision, values, and principles. I'll also just add a little piece here to say this is inclusive of the required elements of a comprehensive plan and also what we call the foundational elements, or the things that we've found in practice with teams and others have found in practice with their teams to be instrumental in making these to be what we'll say truly comprehensive, right? Not just checking the boxes, but really aiming to create a collaborative approach that is sustainable long-term beyond the funding streams. So you'll see that peppered into this as well, and that'll be made much more clear in the toolkit, which are required and which are the foundational elements. So we have a section on conducting community asset mapping and a needs assessment. You'll see developing a theory of change, which I know Michael referenced earlier and is also in the ACL. So the importance of having your collaborative together, developing your hypothesis, right? Why do you think the strategies, the services, the approaches that you're going to try are going to get you to that North Star, right? Referencing the vision that Alex spoke about again in the pre-institute on Wednesday. So that is the third section there. And again, within that, you have subsections selecting your primary, secondary, and tertiary. The secondary portion of the toolkit will be around service planning. And that gets much more into your selection of EVPs, workforce and training, ongoing monitoring and CQI, and developing spending and sustainability plans, which as you know are to come, but we did want to include it here. Developing a collaborative communications plan, which is one of the foundational elements we highly recommend, especially if you are a county that has a larger county with multiple collaborative groups. And again, how do you align those groups and how do you ensure that there is communication amongst those groups, whether that be a person who takes that piece on, whether there's a newsletter, or what does that communication look like to keep your groups aligned and informed of each other's work, right? Because not everybody can sit on every group at all times. So we do have some resources there and do recommend that. And then there's a section 9, considerations and additional requirements for Title IV agencies and some additional resources. So if you have any questions, please feel free to put them in the chat throughout this piece. We really hope for this to be sort of more informal and conversational, definitely educational. I am going to show, though, a few of the tools that you can access through this webpage. So for folks, Lola, did my screen switch over okay? Okay. So we did a recent webinar with Junius Williams, who is a consultant for FSG and the Aspen Institute and the Collective Impact Forum. And Junius went much more in depth into the community engagement toolkit that he helped to co-author and develop. And so we do have that recording, which I'm sure someone here can drop into the chat. It's on our Strategies YouTube channel, but also goes much more into, so the why around community engagement. Why does it matter, especially now? And has a step-by-step guide on how to be results-driven and purposeful with your community engagement. And I really love this chart here that Junius referenced, which is the community engagement spectrum. I know Lydia's used this with a number of the county teams we support, but I really encourage you, whether you go into this deeply or not, to take a look at this chart, and it helps you to think about, as a group, where are we in our community engagement? How are we interacting with community and those with lived expertise? So again, I highly recommend taking a look at this, and that is available through the site. Additionally, I'm going to point out one more tool, and then I will keep it moving. So I want to also draw your attention to asset-based community development, or ABCD, easy enough to remember. And there is a toolkit available through asset-based community development. And again, I won't go into the tool deeply, but one of the things I really feel like is worth saying is that a big principle of asset-based community development is it reflects the need for and encourages community to be a part of the process, to be integral into the process. And Kush mentioned asset mapping in her presentation as well, sort of thinking about asset mapping as it relates to developing your evidence, choosing your evidence-based practices. What's currently being used in your communities? This can take that even a step further, and to look at, well, what are the assets that community members bring, that service providers bring, that those with lived experience bring to this process? You know, how are we going to develop interventions without those folks at the table? It begs for us to say we're repeating the same processes that we've done over and over again. So part of this, again, to Kush's point, doing something new, and part of the asset-based community development is take it farther, right? Get your community members engaged and to be a part of it. In addition to what you'll find on our website, we also have some upcoming learning opportunities. And as Lola mentioned, there are a series of wonderful webinars and learning opportunities coming up from a wide variety of solidly knowledgeable providers connected to and working with CDSS, as Kush mentioned. So our next webinar that's coming up is Tools for Comprehensive Prevention Planning, really looking at the capacity assessment and the capacity assessment tool. And that's coming up on June 21st from 10 to 12 p.m. And we do have a registration link, which I'm sure someone will drop in the chat. And you'll see that we'll be working with our partners at the Population Change Institute for that capacity assessment webinar. They'll be supporting and have been doing some work in some of the counties here in California around that capacity assessment tool, some PDSAs with it as well. So what we imagine to come out of the data that gets received back from the capacity assessment tools that are going to CDSS is some identified themes and topics, which we imagine we'll have future webinars on. And we're already in talks with Paul about doing a data playbook sort of clinic, much more hands-on about how to use the data playbook tools. So what are the, he mentions in the toolkit a lot of different points for data, kids data, Casey community opportunity maps. So really going hands-on into how do you explore those? How do you extract what you need from those? Asset mapping and needs assessment, and engagement of key stakeholders. All right, now we'll hear from Jess at Caltrans to talk a little bit about the upcoming opportunities that they have.
Hello, everyone. My name is Jessica Matley. I am a training coordinator and facilitator with the state-funded program called the California Training Institute, but I believe most of you know us as Caltrans. We support child abuse prevention through free professional development and learning opportunities to child and family helping professionals in California. And I see some names that are familiar, so it's nice to see you again. You might have heard Kush earlier, Dr. Cooper, mention the 5 protective factors: primary prevention, how it helps reduce the likelihood of child abuse and neglect. So I want to expand on that just a moment and also tell you where there is training and support for all of those looking to learn more. So the Strengthening Families Protective Factors Framework. It's an evidence-informed tool which helps professionals work with children and families to promote the optimal development of all children while protecting vulnerable children from maltreatment. So I'm excited to share that starting in July, which will be here sooner than we know it, Caltrans will be facilitating a Protective Factor of the Month training experience. This training was designed for anyone who works with children and families and focuses on concrete ways you can support the building of protective factors in your work. So, little context, each month, Caltrans will focus on one protective factor. We'll deep dive. We're going to offer a training experience in a webinar format for those that prefer more of a lecture, not really a small breakout groups kind of a person. We've got that for you, but we'll also offer a workshop format. And that workshop format is going to be for learners that really love high interaction, small group discussion, much more brainstorming and collaboration. So we've got something for everyone. And what I'm dropping into the chat right now, which you should see there, this is going to be where you'll sign up. So Kicking off in July, we're going to start with the overview of protective factors, a nice once over before we start diving into each one individually. If you click on that link, you'll be able to see that there are a couple different formats that you can sign up for, depending on your learning style, maybe your schedule and your availability. The last thing I wanted to mention, we put together a blog on our site about protective factors and where professionals can find free training and support. We're constantly updating that with new and better information that we find out there for you. So I'm going to drop that for you as well, just so that you can keep it. And if you are in need of a refresher, this would be great for learners at all levels. So whether protective factors is your love language, this is for you. You can find some practical application. If you are not as familiar, you can recognize a term, but you would really love some more concrete information, this is also for you. So we hope to see you there. And of course, if you're looking for more information, as always, on Caltrain and trainings, you're more than welcome to click our link. Our website's caltrain.org. Thank you so much. I believe next, Kush is up. We're going to talk a little bit about a learning series.
Implematics and Casey Family Programs have designed and are going to partner with Caltrain and CDSS to deliver learning sessions on the readiness areas. That's where we're going to focus. So the first one on 629 is there'll be a brief overview that goes deeper into all the readiness areas. There's going to be a special focus on fiscal on 629. Then on 720, we will delve into the matter of governance and cross-sector collaboration. And the special focus there would be meaningful engagement of stakeholders, particularly tribes and those folks with lived experience. In August, we'll focus on implementing the design, your design of your comprehensive prevention services system. Then in September, we'll focus on EBPs, service quality, and strategies around model fidelity. How do you connect certified practitioners to organizations, to the state, to the federal government? Right? How does that all work? Training and workforce development and policy in October. And then in November, we'll put it all together and hopefully position you to submit a plan to CDSS that actually is implementable, right? So writing the plan with implementation in mind, rather than it being a nice idea. And then in between each session, we will have a Q&A event where we will have collected what we're hearing once we, from our stakeholders, what CDSS is hearing through, their TA processes, and we'll answer many of those questions, probably not all of them at those Q&A sessions. And likely more will come up from those that are participating.
There's a variety of things that are on the horizon. So you can attend one of the many upcoming webinars and training sessions that are happening. You can start to explore and utilize the resource page on our website for comprehensive planning. We are currently working with the Department of Social Services on a technical assistance request form that will help with figuring out where exactly you need the assistance. In the meantime, please continue to use that FFPSA Prevention Services email to request any TA or have any questions that you might have answered. You can connect with others in your region or throughout the state, right? And keep an eye out for an invitation to join some CAPC network gatherings that are going to be happening. The toolkit and template, as we've said repeatedly, are going to be coming soon. And again, there's that email where you can submit your questions, request technical assistance, whatever the case may be. Okay. There's a great question. To be clear, should the collaboration team be formed prior to the capacity assessment? And I'm going to ask someone from CDSS to respond to that.
Training. So the capacity assessment is really an assessment to evaluate your motivation for change. What is your team members? So we'd hope that you would have some members of your team established prior to completing the capacity assessment. We understand that as you develop your needs and you complete your asset mapping, you'll recognize what additional partners would be helpful to have at the table. However, it's important to kind of consider this process as jointly as possible. Those core key members of your prevention planning team should be involved in the process.
We have another question about whether the trainings will be available in county and in person. I know for Strategies TA and Caltrain, I think we're looking primarily at webinars. Kush, do you all have anything different planned?
Right now, we are contemplating the learning series to be online. There may be opportunities for meeting on the ground, but those are just hard to predict right now. So we're going to keep it online.
For those counties hiring independent consultants to assist with their comprehensive prevention plan development, please let CDSS know so they can include them in their communications. And she put the FFPSA inbox information there too. Thanks, Kelly.
And then Terry Gillums is asking if credit will be provided for training.
I can say for the strategies trainings, we don't provide CEUs, because I'm not sure about the series.
We haven't talked about it. I'm open, if I'm open. Talk to me, Terry.
All right, thanks everyone. We'll see you soon.